Hello, everybody. Welcome back to the Incubator and Neonatology Review Podcast. We are back with Rooney talking about cardiology. I think we're talking about the PDA today, Rooney, right?
Yeah. We're going to talk about the PDA more in how the PDA closes, not the whole controversy around whether or not
to how to get it closed,
no,
just how it
closes. Because it's actually a fascinating thing because we talk about PDAs all the time, right? Mm-hmm. But let's think about how does it actually close, and that's what this is about. So. No controversial statements here today. Fine. Yeah. Anyway, so review arterial wall structure real quick. You have the tunica intima, which is the inner layer, the tunica media, and the tunica externa.
Sure.
Okay. The ductus has the same thing, and it turns out that kind of from a physiological standpoint or kind of histological standpoint, where the perfusion. And so these are living cells, right? Smooth muscle cells. They need oxygen. They need glucose. And turns out that if the vessel is greater than 0.5 millimeters, so greater than half a millimeter, they need their own
half a centimeter.
Millimeter. The wall.
Okay.
Yeah, exactly. Because this is not the whole size itself, but actually just the wall.
Got it.
Yeah. So then it needs its own vascular structure. Okay. So then it has something called the vasa vasorum. Okay.
Yeah, the vessel of the vessel.
The vessel of the vessel, and sometimes also called the vasa privatum, your own private vascular structure that comes in there. So so the way and obviously the tunica media, which is in the muscle media, which is in the middle of the wall, is the area that's at highest risk of having kind of perfusion issues, if you will.
It's like a watershed area.
Yeah, exactly. So the tunica media has this frequently this avascular zone as part of the lumen. Okay, and this avascular zone depends on diffusion from inside the lumen and from the vessels, the vasa vasorum, that comes in from the outside. Okay, and then you have this one watershed area that is vulnerable to exchanging oxygen supply. Okay, and here again, this is the tunica media. Here's the tunica intima. It's a little smaller here, and this is kind of the largest area with smooth muscles. This is the kind of the avascular zone at risk of perfusion issues. Again, because the vessels are coming out from the outside and in and supplying this area here nicely with blood vessels. And from this area here, you have diffusion from inside the lumen because there you have obviously glucose and oxygen, everything circulating around. So there are, for like big picture, 3 factors that can kind of reduce or increase hypoxia in the vessel wall, and that's a kind of decrease in the luminal or vasovasorum blood flow, obviously, and an increase in the diffusion distance, so the thickness. So if you can't really diffuse past a certain point, and if you also have an increase in oxygen consumption, obviously in the muscles. Okay, so like I said, vessels thinner than 0.5 millimeters have no vasovasorum, and the tunica media obtain oxygen only from diffusion from the lumen or the vasovasorum of the adventitia. Okay, so that's a very vulnerable thing, and this is kind of becomes pertinent to us when it comes to the ductus. Okay, it's just a summary slide. So the thickness of the avascular zone and the distance from the source of which is kind of it diffuses in really has an effect on whether or not that area gets perfused or not.
Yeah,
Again, somewhere around 0.4 and 0.5 millimeters or 400 to 500 micrometers. Yeah. We know that the ductus in utero it's kept open by low fetal arterial oxygen tension, an elevated concentration of prostaglandins circulating mostly from the placenta, and local productions of prostaglandins also in the ductus itself, and And all this kind of continues to keep that ductus open. And when you're born, different things that happen. So, and there are kind of two steps to that closure. You have an rapid increase in PaO2, and a rapid decrease, almost sudden decrease in prostaglandins, which results in construction of the smooth muscle.
Yeah.
And when you construct the smooth muscle, it actually becomes thicker, right? It doesn't get thinner. It's like your normal muscle, it gets bigger, right? So that increases the distance in which things need to diffuse into the tunica media, and increases the thickness of this avascular zone. And the constriction also kind of puts some pressure on this vasa vasorum, so that the perfusion through it is actually poor, because it actually increases the afterload in that microcirculation, if you will. So all these things together makes it so that this the effective avascular zone expands greater than 0.5 millimeters, and then you actually have ischemia in that area. Okay, so this profound ischemia in the tunica media causes local cell death in that region, and ultimately makes it so that as they're dying off, that turns into scar tissue, and the environment becomes more acidotic because you have apoptosis, and the cells are all kind of in chaos, and more cell death, and then before you know it, you basically have the entire tunica media being necrosed off. That turns then ultimately into this a closed ductus.
Huh. Okay.
Yeah. And what about premature neonates? Okay, so why does it not close in preemies? Is really because the premature ductus is very thin, is less than 0.2 millimeters or 200 micrometers in thickness, and that's one of the reasons why
it doesn't meet the criteria for its own private perfusion.
Does not have its own private perfusion, and the avascular zone never becomes ischemic, right? Because it diffuses through. That's one of the primary thoughts behind why.
So you're saying that because the thickness is so reduced, there's really no watershed area, because it gets enough to actually sustain itself.
Exactly.
That's so interesting.
Yeah. And I think that's just, since we talk about the ductus all the time, it's nice to just kind of know that this is part of the physiology, right? So it does not thicken to the extent that it could result in hypoxemia and necrosis of the tunica media. So this is the classic kind of image. You have the vasa vasorum coming down here. This is a
full-term ductus.
Yeah, this is the fetus. This is a newborn. This is a preterm. So here's in the fetus, you have this area here is less than 500. So this stays open, right? And then here's a vasa vasorum coming down here. So you don't have a watershed area. Here in the newborn, you have the vasa vasorum that comes down, but then all of a sudden
it contracts. It contracts, and that's why you said that the thickness gets larger, so that distance now suddenly is increased.
Yeah.
And so now you have a larger watershed area, and there can happen.
Yeah, exactly. And here you have a preterm baby that that really does not reach the criteria for ultimately having a watershed area, and then therefore you never reach the moment of actually cell death in the wall. Yeah. So that's kind of our attempts to try and close it, is really to try and make it kind of constrict so that it actually becomes thicker. And can you reach that that kind of level of thickness where you start having areas of necrosis? Where you
can create that ischemia.
Yeah, exactly.
We want to create ischemia, which is rarely something we want to do in medicine.
I know, exactly.
But in that case, that's what we're aiming to do.
In this case, yeah. So I think this kind of helps me talk about the ductus sometimes when we don't talk about the physiology or closure. But I find this often very nice knowledge to have at the bedside.
Absolutely. Yeah. All right. Thanks, Ronnie.
Thank you.